everyone, and welcome. Today, we are diving deep into a condition that can be a true medical emergency, angioedema. This is going to be a super high-yield clinical review, perfect for getting you razor sharp, whether you're on the wards or prepping for your exams. Let's get right into it. First off, before we go any further, we've got to give a huge shout out and full credit for the content of this explainer to Dr. Mohammed Al-Nagi Mohammed. His work is the foundation for the fantastic clinical journey we're about to take together. So here's our game plan. We're going to start with the basics of angioedema. Then, and this is key, we'll unpack the two critical pathways that honestly guide every single decision you make. From there, we'll walk through the diagnostic workup, what to do in an acute emergency, and finally, how to think about a long-term strategy for your patient. It's the whole journey from start to finish. All right, let's kick things off with Section 1, the absolute fundamentals. So when you see a patient with this really dramatic swelling, what's actually happening on a physiological level? What's going on under the skin? Well, when you boil it all down, angioedema is all about leaky blood vessels. It's this temporary, localized swelling that happens way down in the deeper layers of the skin or the mucosa. You're probably picturing the classic sites right now: the face, the lips, the tongue, and, the one that really gets our attention, the larynx. Because when it involves the larynx, this whole thing can become a life-threatening airway emergency in a hurry. Okay, let's make this real right away. Imagine this. A patient walks in. You know they're on an ACE inhibitor, and their tongue is acutely swollen. Your first instinct, your reflex, might be to reach for steroids, right? But is that the right move? Just hang on to that question, because the answer is at the very heart of everything we're about to talk about. And that brings us right to the answer, Section 2. Okay, this next part, this is where you really need to lean in. Seriously, this is probably the single most important concept in this entire explainer. If you can get your head around these two pathways, you're going to be able to nail the diagnosis and management every single time. Okay, this slide right here, this is everything. This is the fork in the road. Your entire management hinges on one question. Is this driven by histamine, or is it driven by bradykinin? And the clues are right here. Histamine, that's your classic itchy, hivey reaction. Bradykinin, no itching, no hives. And this brings us back to our question. Histamine responds beautifully to steroids, but bradykinin-mediated angioedema, the kind you see with ACE inhibitors, does not. And giving the wrong treatment here isn't just a waste of time, it's dangerous when an airway is on the line. And this table kind of breaks down the why behind it all. On the histamine side, you've got your usual suspects: allergic reactions to food, drugs, bee stings, or sometimes we just don't know. It's idiopathic. But the bradykinin pathway, that's a whole different animal. This is where your ACE inhibitors live, along with those hereditary and acquired forms of C1 inhibitor deficiency. Totally different mechanisms, totally different causes. Okay, so we get the two pathways. We know they're different. So how do we actually figure out which one we're dealing with? How do we go from what we see at the bedside to a solid diagnosis? That brings us to Section 3, the diagnostic workup. So when you're examining the patient, you're obviously looking for that localized, often asymmetric swelling. But don't just stop at the swelling. You've got to ask about other symptoms. GI involvement can cause just awful abdominal pain, nausea, and diarrhea. And you always have to be listening for signs of laryngeal swelling, like a high-pitched stridor or a change in their voice. And I'm going to say it again because it's that important for your exams and your practice. If there's no itching, you have to be thinking bradykinin. Your workup should follow a really logical step-by-step path. First up, in the middle of an acute attack, the diagnosis is clinical. It's based on all those features we just talked about. Second, you have to do a meticulous medication review. Is an ACE inhibitor on that list? And then third, if you've got someone with recurrent attacks, that's when you start sending labs. A C4 level is a great screening test to start with, and if it's low, that points you toward checking C1 inhibitor levels and function to really nail down that diagnosis of hereditary or acquired angioedema. All right, now we're shifting gears. We're in the emergency department. Things are getting real. This is Section 4, acute management. The clock is ticking and every single move you make counts. Before you do anything else, before you even think about what drug to give, before you try to figure out the cause, it's one thing and one thing only: the airway. This is your absolute non-negotiable number one priority. You're assessing for stridor, any respiratory distress, voice changes, and you need to have a very low threshold to call for help early from your anesthesia and ENT colleagues. Securing the airway trumps everything, period. Okay, so the airway is safe. You've figured out it's a histamine-mediated attack, the one with the itching and hives.
The treatment here is probably what you're expecting. You stop whatever caused it, you give antihistamines, you give corticosteroids, and of course, if there are any signs of a bigger anaphylactic reaction, you're going to give IM adrenaline. This is your classic allergy management pathway. But what if it's bradykinin? This is where that fork in the road we talked about becomes a matter of life and death. Let me be super clear. Antihistamines and steroids will do absolutely nothing here. Giving them is just wasting precious time. Instead, you need the big guns, the therapies that go right after the bradykinin pathway. We're talking about things like C1 inhibitor concentrate, which replaces what's missing, or icatibant, which blocks the bradykinin receptor. Now, if you're in a spot where those aren't available, fresh frozen plasma can be a backup, but the specific therapies are always what you want to reach for.
Okay, the emergency is over. The patient's stable, they've been discharged, but our job isn't done, right? We have to think long-term. So let's get into our final section, building a strategy to prevent this from ever happening again. So long-term management is really all about prevention. First things first, get rid of any known triggers. If it was an ACE inhibitor, that drug is stopped for life, no exceptions. For anyone with a hereditary condition, a specialist referral is absolutely essential. They're the ones who will guide the prophylactic or preventative options. That could mean regular C1 inhibitor infusions or some of the newer drugs like lanadelumab, which helps prevent attacks from even starting. And that brings us to our final thought for the day, one of those gray areas we all run into. So imagine you have a patient with recurrent swelling, no hives, you've stopped their ACE inhibitor, their initial labs come back normal. We label it idiopathic. So my question to you is, what's your threshold to keep digging? How many attacks does it take before you push for more advanced testing or another specialist review? Where do you draw that line? Just something to think about in your own practice.